I'm Jessica Lovell, and welcome to the Morning Medical Update. High cholesterol is normally a concern for people who are middle-aged or older. It typically takes years, even decades, for plaque to build up inside your arteries. But today, we are asking when and if kids should get their cholesterol checked. And spoiler alert, not all doctors agree on the answer. Some groups recommend universal screening between the ages of 9 and 11. Meaning that every child would need their cholesterol tested. But a new study shows only 1 in 10 children get that test. The review recently published in JAMA Network Open showed that between 2018 and 2021, only 11% of kids and adolescents received a cholesterol test. Among the kids that did get that test, 30% had an abnormal result. And we are learning more about these tests and when they make sense for kids. From 3 of our doctors here at the University of Kansas Health System, we have Dr. Stephen Lauer, pediatrician. Good morning.
Good morning.
We also have Dr. Ken Gertz. He is a pediatric cardiologist. And next to me is Dr. Patrick Moriarty. He specializes in preventing cardiovascular disease, and he is the director of the health system's Atherosclerosis Lipid Apheresis Center. How are you?
Very good, thank you.
Good. Docs, good to see you this morning. Thanks for being with us. But before we jump into this discussion, we want to discuss an extreme example of high cholesterol in kids. Alexis Del Cid introduces us to a little girl whose cholesterol was so high it was coming out of her skin. And if she didn't find treatment, she was at risk of a heart attack.
They put the needles in and then they clean my blood.
10-year-old Aubrey Bell knows more about science and medicine than anyone her age should.
When I was 2.5, I got diagnosed with it.
She's had plenty of first-hand experience.
It's about 8.5 hours here and then it's 8.5 hours back.
And even though it's grueling driving to Kansas City every 14 days from their home in South Dakota, causing her parents to miss work and Aubrey to miss school, they feel fortunate.
There's a good chance I wouldn't have a daughter anymore if we weren't getting this treatment.
This therapy of apheresis is very rare in the United States for treating this kind of disease. Now we have the largest center in North America. We treat more patients here at KU than all of Boston, New York, Chicago, LA, combined.
Aubrey has familial hypercholesterolemia, also known as FH. It's a genetic disorder that makes Aubrey's bad cholesterol sky high. Medication won't lower it. The only thing that works is this treatment, administered by Dr. Patrick Moriarty at the University of Kansas Health System. It's called lipoprotein apheresis.
The cholesterol goes down in the red bucket.
These machines filter the bad cholesterol from Aubrey's blood and then put the clean blood back into her body. But reaching Dr. Moriarty and his team was a 5-year-long process, even though the signs were there beginning when Aubrey was just 2 weeks old.
They just said it was probably a fungus or something.
Her mom, Jade, says she noticed orange patches developing on her baby's skin. She says the doctors in South Dakota told her it was because she wasn't bathing her properly.
It was frustrating that I was being blamed.
Over the years, the orange patches got worse, and still, she says, the doctors wouldn't listen.
It honestly almost looks like orange sherbet was the shade of the orange, and it looks like little bubbles, like kind of like a smaller blister.
It looked like an orange peel.
Finally, she drove 2 hours to a dermatologist in another town who correctly diagnosed the orange patches as xanthomas, and further testing revealed something horrifying.
He did do a biopsy and a blood draw, which her cholesterol was almost 1,000 at that point.
There was so much cholesterol in Aubrey's tiny body, it was seeping out of her skin, creating the orange deposits.
I always say go with your gut feeling. As a mom, you know when something is wrong. And unfortunately, sometimes we have to be our own advocate and push for the answers that we need.
It was Jade's persistence that landed them here for this treatment, a place where Aubrey is surrounded by a care team that has really grown to be like family.
They're so nice. They spoil me. Halloween, my birthday, Christmas, Thanksgiving.
And she has big plans for the future.
I want to move to New York and be a fashion designer.
And if you would like to hear more from Aubrey and her mom, you can check out our previous episode of All Things Heart titled Lipoprotein Apheresis. Now, those deposits on Aubrey's skin are what led to a diagnosis. But in most cases, we can't see a cholesterol problem. That's why a blood test may be really important, which brings us back to our discussion. When do kids need a cholesterol test, also called a lipid test or lipid profile? Now, some groups like the American Academy of Pediatrics and the American Heart Association and the American College of Cardiology say that all kids need a cholesterol test around the age of 9. But Dr. Lauer, so what's the logic behind this universal testing approach?
So it's really to address those kids and identify those kids who have FH. That was the goal of when the recommendations came out, just because it's so, as you said, you can't tell just by looking. Now, again, we say one of the best ways to do that is to do the parents know their medical history and what's going on. That certainly helps identify some risk, but because that's more uncommon or less likely to be true than we'd like it to be, the AAP and those other groups came out with the recommendation that every child be screened for cholesterol between 9 and 11.
Dr. Moriarty, what are your thoughts on universal testing?
Well, I look at guidelines, and I tell my residents and students and fellows, they're to guide you, not to dictate to you. They're guidelines. And every patient is separate from anything else, and you have to dictate by that patient, the patient's medical history and so forth to make a determination. Universal testing of lipids, I find could be used, but I don't put it as a high priority for young people, unless there's a family history, unless there's other relationships to this child that really requires it immediately. What I do recommend, though, and this is something that's going to happen more common in the future, is FH, as we were talking about. The heterozygote FH is 1 in 250 people. Homozygotes, which this young girl had, is 1.5 million have that. So 1 in 250, that's a large difference. But there's another cholesterol that's out there that we're learning about, that's been out there for a long time. It's called lipoprotein A, or LPLA. That's found in 1 in 5. 20% of the United States population have an LPLA. And unlike LDL and other bad cholesterols, it never changes. Once you're born with it, you have your rest of your life. It's a triple threat for cardiovascular disease risk, and presently we don't have an official drug approved for it. We're working on some drugs here at KU. We have 2 studies going on right now, and there's a new technology called CRISPR. You ever heard of that?
Yep, we've done a show on it.
Yes, it's fantastic technology. I'm working with the CRISPR company in Cambridge, Mass. We're developing a trial using CRISPR on patients with high LPLA, because they're working on this genetic deletion of this gene that causes this lipoprotein A. You know, we all measure thyroid disease in our patients here in the United States. Roughly 20 million people in the United States have a thyroid dysfunction, according to the Thyroid Foundation. 20 million, which is 6%. We have 20% with high LPLA, and in Europe, in Canada, because they recognize the risk of this lipoprotein and the lack of change, they recommend universal testing for all adults in Europe and in Canada. We don't have that yet here. We have less than 1% of adults in the United States have been tested for LPLA. Children, forget it. I have an 11-year-old boy who sent to me from Children's Hospital, came here because he had multiple strokes. He had a basilar artery thrombus, and the IR team had to remove the thrombus, but his neurological deficits continued. And it turned out his LDL was 60, but his LPLA was 360, where normal was less than 30. He's now 20 years old. He's been on my machines for the last 9 years and has had not another vascular event. And pediatric strokes, as you guys will admit, is not common. But 40 to 50% of pediatric strokes is idiopathic. You don't know the mechanism. How many times is LPLA checked in those patients?
Probably 0.
0. And we know potentially 40% of those could be related to high LPLA. It's not being tested. And apheresis is the only present therapy approved for treating LPLA.
Dr. Gertz, jump in.
As a pediatric cardiologist, one of our goals is to try to prevent disease. We take care of babies and children born with congenital heart disease, but we also have an interest in trying to prevent disease. We don't know what it takes to prevent disease in adults. We have good ideas that the process begins in childhood and adolescence, so it makes sense to try to step in and do things before crisis develops, heart attacks develop, things like that. But what's the best and most effective and cost-effective strategy is yet to be determined.
So it's a pretty simple test though, right?
It's a very simple test.
Dr. Lauer, do parents come in asking about kids' cholesterol? I mean, let's be honest, I'm thinking of the things that my kids eat, and when we talk about adults having good cholesterol, we talk about the foods they're eating. So when you think of the junk that sometimes gets in our kids' hands, is that something that parents should be worried about? Do they ask you?
They should be worried about it. No, they don't ask. And that's, I think, one of the ones is getting this message into the hands of the parents of our kids, very few of whom know their own cholesterol status, is one of the messages. But except for those families where they do know that they have, one of the parents or both has some family history of high cholesterol or early cardiac disease, no, they don't ask.
Okay, so we talk about this being a simple test, this blood draw, but you also have to fast, is that correct?
No.
How do you get a kid to fast?
You don't necessarily have to fast for the screening test. In the lipid profile, you're measuring cholesterol, total cholesterol, LDL cholesterol, and HDL cholesterol. The one thing that's variable is triglycerides. So that's the lipid that is affected by fasting versus non-fasting. There are studies going back to the 1980s where they were doing screenings in different populations. And the one I remember was in Cincinnati, where they had about 10% of the children involved in the screening process that weren't fasting, and they looked at their cholesterol levels and then got later fasting ones. And pretty much the total cholesterol, HDL cholesterol, was the same whether they were fasting or non-fasting. It was the triglycerides that changed. So you could do a non-fasting lipid profile in the clinic, and if everything is okay, you're okay. Now, the question is, do we add the LP little a in there as well? Which we probably should be doing as a one-time measurement.
Yes.
And if you've got that and it's all okay, you probably don't need to repeat that again for a number of years. If you have high triglycerides, then you should get a fasting lipid profile.
Okay, so a lot of that goes over my head. So Dr. Lauer or Dr. Moriarty, jump in and tell me exactly.
Well,
because
we look at a fast and non-fasting lipid panel, similar to what an endocrinologist, a diabetologist looks at a 2-hour postprandial lipid sugar levels compared to a fasting sugar levels. Meaning, if you have eaten within a 2-hour period and your sugars are a certain level, above 200, that's too high.
Okay.
If you're fasting, it should be under 100. Same thing with triglycerides. If you ate a meal and your triglycerides are 400 or 500, that's too high. It should be less than 150, less than 100 if you're fasting. So it varies on, as was brought up, your food that you eat. Triglycerides are called acute phase reactants, meaning if you eat a meal, they shoot up right away. If you don't eat for 24 hours, your triglycerides go down by 50% right away. So it's equal balance. So if you have an abnormally high triglycerides with or without a meal between it, there's something going on that's not right.
So I want to hear from all of you, just back to the test, on what are the arguments against universal testing? Is it against, or is it just not necessary?
Well,
go ahead.
I'd say make the same point that Dr. Moriarty did. We try and teach our residents and med students not to order tests that aren't going to change your therapy. And the reality is that the first line therapy for high cholesterol levels or abnormal lipids, with some very unusual exceptions, is to encourage a healthy diet and more exercise, which is what general pediatricians do every day for every patient, as you may remember. So, I mean, that's it. The test results at 9 or 11, in the vast majority of cases, are not going to change what we do and what we're doing every day anyway. So to my mind, a lot of it is like we need to keep making the messages about healthy diet and exercise lead to appropriate lipid panels.
So what kind of evidence would it take to demonstrate that universal lipid testing is worthwhile? Are there, what kind of?
We can do epidemiology data of collected lipids of young people and follow them for a period of time. And when it comes to back, that's the thing we got to realize is good cholesterol. We all need cholesterol. If we don't have cholesterol in the system, we're not going to survive. It's a major metabolite of cell membranes and so forth, and so many hormones and so forth. But there's so-called bad cholesterol. And we're realizing now that there is no good bad cholesterol. As a species, we've kind of grown out of the need of it. Like Lp(a), we have no need for that. LDL, really, there is no need for it. Like we don't need tonsils and appendix, we don't need these bad cholesterols. HDL, which is the good cholesterol, is a very complex story because low bad HDL is not good. But even now we're learning a high HDL, meaning above 80 milligrams per deciliter, could be detrimental. Reason being HDL is a very complex protein, has many other proteins binding, unbinding to it, which can change the so-called functionality, which is a whole different story. But it's a complex story, and as Dr. Lauer brought up, I think using your intelligence as a trained clinician to see that patient and determine based on the patient's medical history, the patient's lifestyle and so forth, you determine if you should do testing on this patient. But when it comes to Lp(a), we don't know. 20%, 1 out of 5 of the patients in the United States have it. And that's something that should be standard practice of measuring just to see if someone has it for down the road for future cardiovascular risk.
If we go back to Aubrey's case, though, had that not have shown on her skin, would that have just gone undiagnosed?
Well, with her, she was a homozygote, which was pretty rare not to have the xanthomas. But because of her family history, her mother, her father, her mother's mother, they all had high cholesterol. They all had cardiovascular disease, or risk, or at least had disease. So there was a history there that a clinician should have known that and should have tested that child at a very young age, because it was pretty obvious that child had the potential future risk of a cardiovascular event based on her genetic cholesterol problems.
So be sure to ask your questions. You can use the chat on YouTube or Facebook. You can email us at the Medical News Network. Information right there on your screen. So Dr. Lauer, if my son or daughter gets a lipid test, the results come back abnormal, what's the next step?
Well, just again, following up what Dr. Moriarty said, you take a look at their family history, get more information about that, understand how old they are, where they are in their pubertal development, because that can affect and have some changes in lipid profiles. What's their weight, what's their diet and exercise profile, and have them in talk about those results. And again, the first line is stressing that the importance of the healthy diet and exercise. Where can we make changes in that? Have those, try and get those in effect, have them talk with one of our dietitians, something like that, and then have them back in some time frame. These things don't change quickly, so 6 months, have them repeat the lipid profile and see if we're making any headway. If there are persistent problems, things that seem to be really changing and getting to the level where we can't affect it, we have them talk with Dr. Gertz.
So, Dr. Gertz, when would it make sense to prescribe a statin for a kid?
I look at this in several different areas. One, what's the family history tell us? So early events in parents or grandparents are a significant factor. The youngest child I've ever prescribed a statin to was a 4-year-old child, and that was 30 years ago when statins were just coming out. And that girl's father had a heart attack when he was 29, and her total cholesterol was 400 something. So there was evidence at that point that something needed to change. That's an unusual event. Most of the children I see are older children and adolescents, and unfortunately their problems with lipids are commingled with obesity and metabolic problems, pre-diabetes or sometimes even overt type 2 diabetes, which has additive or multiplying effects on cardiovascular risk. So right now, probably the #1 reason why I'm prescribing lipid-lowering therapy is insulin resistance or type 2 diabetes and abnormal lipid profiles.
So what circumstance would it lead to someone younger than the age of 9 needing one of these tests?
Aggressive family history.
Okay. So Dr. Moriarty, if high cholesterol is not detected, it goes untreated, what is the long-term effect?
Well, long-term effect is the development of so-called atherosclerosis, which is the abnormal depositing of so-called bad cholesterol within your arteries, which eventually can progress into symptomatic heart attack, stroke, and so forth. So it's kind of, I look at like hypertension. When you diagnose someone with hypertension, you just don't say, okay, you have hypertension, let's see what happens. No, you start treating with medications. You lower the blood pressure because that chronic hypertension can affect chronic kidney disease, heart failure, even cerebrovascular events. So you aggressively treat it then. And I look at the same thing with bad cholesterol. If I see a significantly high bad cholesterol that, despite aggressive diet and exercise management, I might have to use medical management, as Dr. Kurtz did in our 4-year-old child. And his newer therapy coming out in this CRISPR technology is incredibly possible to do magnificent things, as you saw with sickle cell anemia now. So the future is endless when it comes to genetic diseases of this kind.
So the guidelines that recommend the lipid testing around 9 also say that those tests should be done again at 18. So what's happening in that time frame? Why is that?
Well, teenager years.
Adolescence.
Growing up.
So again, these guys are much more expert, but knowing a high cholesterol level at 9 is predictive but not perfect for your cholesterol level at 18. A low cholesterol level at 9 is predictive but not perfect to say you'll have a low cholesterol level at 18. So it's just keeping track of those changes that happen, pubertal changes growing into adolescence that occur metabolically in patients, and just trying to confirm that they've stayed on that pathway.
Yeah, it makes sense. You're entering adulthood.
Yeah. The differences between rising testosterone levels in males and impact on the different components of the lipid profile versus increasing estrogen levels in children who become young women. Those have different effects, and you're seeing what the impact of that is. And 18, almost all children have completed puberty by the age of 18, so it tends to be predictive of what young adulthood and early adulthood is going to be like from a lipid profile standpoint.
Let's get to some questions from our viewers this morning. And Marcia has a question. Dr. Lauer, I'll ask you. So a parent comes in, they know their family history. Should they just jump in and ask you to get this test? You know, what age should someone ask for it?
Well, we ask family history early on in those infant visits too. We're trying to understand the family history of all of our patients, because that's frankly one of the most predictive things about how they're going to do. So if there are specific elements of a family's history that are important and known to cause health problems in that family, your child's pediatrician needs to know about it. And if we're not asking, please tell us.
So she also wants to know, what are some things that parents can do to help kind of set their children on this lifelong good habit path when it comes to their heart health? And we could go around the around the table on this one. Give us some good quick tips.
Healthy eating, healthy diet, excuse me, healthy foods right from the beginning, avoiding excess calories, good exercise regimen. We say the same thing over and over again, from the newborn visits to adolescent visits to the adult world. It's the same message. We have to eat healthy foods, get exercise to mitigate whatever risk all of us carry around atherosclerosis.
Dr. Gertz.
Get outside and play, if at all possible. And that becomes a challenge sometimes, because some of the families we see, their children do not live in safe neighborhoods. Right. And so how do we as a society assist and enable people to do what we advise them to do? It's unrealistic to advise families who's live in unsafe neighborhoods to tell their kids to go outside and play for 2 hours. Yeah. So what are the other options that we can provide? And that, I think, becomes one of our challenges as a society. And I think parents can feel guilty about not following recommendations, where the practical effects of those recommendations may put their children at risk.
Dr. Moriarty?
Well, I agree with what both my colleagues said. I emphasize the exercise as sports as best as you can, and that's important for the schools to have good sports programs for these children, because their physical activity is paramount. Because if they're physically active as a young child as they get to be in adulthood, it kind of sticks around. And this disease of atherosclerosis and cardiovascular disease is nothing new. It's been around since Egyptian times. They find the sarcophagus of these Egyptian pharaohs with atherosclerosis. It's the reason why it's not so prevalent back in those days is people didn't live till 60 or 70 like we do now, which when atherosclerosis kicks in. But if you have a physically active lifestyle throughout your life, that's a very, very strong determinant of preventing atherosclerosis, cardiovascular disease, even dementia now is prevented by this. We talked about that before with our machines that we use. So physical activity is a priority. And dieting, of course, but it's going to be tough to get children to get on a good diet.
It is tough. I'm like sitting here as a mom
fast
going,
food and all that. So
tough.
if you can't do that, do the physical activity first. Push it. So when you're eating a Big Mac, they're burning it off with something else instead at the same time.
Okay, I know.
But dieting is very tough.
It is, because when you say cholesterol, I immediately think of what they're eating and consuming.
Right.
I'm thinking, what are those arteries looking like now and down the road?
I recommend for my patients, I deal with adults mainly, some pediatrics, I bring up the swimming, which everyone doesn't have, because a pool in your basement, so I bring up a water rower, which replicates rowing a boat, but it uses 80% of your muscle groups, and gravity's not involved, so it's no stress in your ankles, hips, and knees. In 1 hour, which is a long time, can burn 1,000 calories.
Good tip. Amy wants to know, if my kid gets a cholesterol test, are there other blood tests that otherwise seemingly healthy kids might need?
In general, in a general pediatrics clinic, we like to go with the idea that you have to have some other sign that something is wrong. We don't go, if they look like a healthy kid and are running around and we think that they're developing normally, there's not a whole lot of standard labs that we would draw. It tends to be based either on family history of something else that's going on in their genetic background or some specific sign that they're giving us, either something about how they're growing, some symptom that they have that would drive towards some regular testing. We try and test young women a couple of years after their first period to make sure they're not getting iron deficient, but there's not really any other standard testing that we do without some indication.
Dr. Lauer, I'm going to stay with you. What's the big takeaway today?
If you want to have, outside of a few genetic outliers, which we need to know about and we can get at and may need to do testing on, the bottom line of staying healthy stays the same. Good exercise, a healthy diet, getting enough sleep, and not putting a bunch of junk in whatever version into your body takes care of a whole lot of the health concerns for the rest of your life.
And a lot of things that you can control, which is good.
And you're all in control.
Dr. Gertz, what's the big takeaway?
Know your family history. Encourage activity. And I think what we're plagued with is 40% of children and adolescents are overweight to obese. So I think collectively trying to help that, reduce that prevalence would go a great way in reducing the kinds of problems we've been discussing.
Dr. Moriarty, wrap us up. What's the takeaway?
Well, I agree with it. My colleagues again.
I know, I leave you last.
Exercise.
Okay.
And I brought up earlier, I'll bring it up again, the lipoprotein A, Lp(a), which is in 20% of our population as a cardiovascular risk factor that doesn't change throughout your life, generally speaking, should be a test that everyone should have at least once to see if they have it. If it's normal, then don't really worry about it because it's not going to go up, generally speaking, over your lifespan.
Thank you for the education, gentlemen, this morning. Thanks so much.
Bye-bye.
Thanks to all of our guests. Thanks to our viewers. We'll see you back here on Wednesday.
Coming up Wednesday on Open Mics with Dr. Stites. Your gut affects your brain, and your brain affects your gut. How does understanding that connection improve your health? I'm Alexis Del Cid. On the next Open Mics with Dr. Stites, we explore the emerging science of the gut-brain axis, impacting everything from anxiety to bloating. And you'll meet one woman who finally understands how her own mental health was making her sick. Wednesday at 8 a.m.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcast. Now, everywhere podcasts are available.